Hi, everybody. My name is Cole Thomas, and today I'm going to be discussing exercise induced asthma and exercise induced bronchospasm. Currently, 300 million people around the world are suffering from asthma, and of those 300 million people, 13% are suffering from exercise induced asthma, or EIA, as I'll refer to it throughout the presentation. Also, 80 to 90% of people suffering from allergenic related asthmas are suffering from EIA. So, what exactly is EIA? EIA is an inflammatory condition of the lungs where the bronchi swell up. That swelling is caused by a combination of heat and water loss in the lungs. This happens because as we exercise, our bodies demand more oxygen and our breathing rate increases, causing us to breathe through our mouths. Now, as we breathe through our mouths, we're skipping the essential step where in the nose we are heating and humidifying that air coming into our lungs. Studies have shown that mouth breathing only increases that humidity by 60 to 70%, whereas the nose breathing increases the humidity by 80 to 90%. Also, the bronchi of individuals with EIA are much more sensitive to changes in temperature and humidity of the air in the lungs. This triggers the mucous membranes of the bronchi to become inflamed, and that effectively narrows the airway, decreasing the amount of airflow that can get through and the amount of oxygenated blood that is going to be circulated throughout the body. Now, EIA is often confused with another condition called EIB, or exercise induced bronchospasm. Now, EIB is a bronchospastic disorder where the smooth muscle in the terminal bronchioles actually go into spasm and contract, decreasing the diameter of the bronchioles. And that decreases our lungs' ability to actually supply our body with oxygenated blood. The symptoms of EIB are also brought on by the effects of cooler, drier air, just like EIA. Now, EIA can also cause EIB and its symptoms. Between 80% and 90% of patients with asthma or EIA also have EIB. One study found that 29% of athletes with coming in for pre-participation screenings actually found that they had undiagnosed EIB. So, since cooler or drier air often causes the effects and symptoms of both these conditions, winter sports that are outdoor would not be ideal for either of these demographics. Now, some symptoms of EIA include shortness of breath, tightening in the chest, coughing, wheezing, and even decreased performance. Also, symptoms of EIB include things like shortness of breath, chest tightness, coughing, wheezing, and also decreased performance. But also, it includes sore throats and even upset stomachs. Now, patients with EIA can become symptomatic during exercise, but most commonly with coughing. This coughing will occur within the first 5 to 10 minutes of exercise, and even after completing the physical activities, these symptoms could arise and peak. Eventually, they'll resolve within 20 to 30 minutes after exercise. But sometimes EIA sufferers will experience something called late phase symptoms, which could arise somewhere from 4 to 12 hours after exercise, and they'll last as long as 24 hours. Now, also, individuals with EIB have their symptoms begin after several minutes of vigorous exercise, but rarely within the first 5 to 10 minutes of exercise. Now, symptoms of EIB occur during the first 5 minutes of exercise. It's typically not indicative of EIB. Those symptoms are more likely associated with something like pulmonary function, poorly controlled underlying asthma, or even poor conditioning or an injury to the chest wall. Individuals with EIB will not become symptomatic during physical activities that only require short bursts of exertion, such as football or even basketball, whereas the vigorous rhythmic exercises of longer lasting athletic events, such as an 800 meter or 600 meter or a 1600 meter sprint or run, will cause the arise of these conditions. Typically, events longer than 5 minutes will cause those conditions. Now, the diagnosis of EIA is easily determined by a doctor. It only includes a series of tests, including a treadmill run, a treadmill or a run test to be performed. Now, the doctor will assess your lung functions using a spirometer before, during, and after these tests. The spirometry basically tests how much your lungs can hold and breathe out forcefully through a small tube, while the peak flow meter test can also will measure how quickly the air leaves your lungs. Assessing the peak flows help your doctor to determine and detect narrowing in the airways before, during, and after these activities are complete. Now, diagnosis of EIB is similar to EIA. Exercise tests are often performed using a bike, a treadmill, or even a run test coupled with pulmonary function tests. Using a peak flow meter, just like EIA, if the patient exhales air force less forcefully after exercise than before, then the differentiating factor between the EIA and the EIB, it will be the differentiating factor between EIA and EIB. Also, trial and error using short-acting bronchodilators to see if it improves symptoms and performance that cause EIB could determine the diagnosis as well. Managing EIA is completely doable. First, the individual needs to assess and monitor their breathing status before, during, and after exercise. Also, taking the necessary medications before exercise is extremely important. There are 3 types of medications available for treatment of EIA. The first one is a short-acting beta-2 agonist, also known as a bronchodilator, which needs to be taken 10 to 15 minutes prior to exercise. It can actually help prevent symptoms for up to 4 hours. The second one is a long-acting bronchodilator, which should be taken about 30 to 60 minutes before exercise, but only once in a 12-hour period. The last one is a cromolyn, which needs to be taken about 15 to 20 minutes before exercise. The short-acting bronchodilators can be used to treat and reverse symptoms once they begin, but long-acting bronchodilators and cromolyn should only be used as preventative measures because they don't offer quick relief. A proper warm-up can also help prevent the symptoms of EIA from arising. Warming up for 6 to 10 minutes before exercise can help prevent these symptoms. Avoiding exercising in a cool, dry condition, such as outdoor during the winter, may also be a great idea in help preventing these conditions, but more specifically EIA as well. Also, the goal in managing EIB is to prevent symptoms. Now, there's a number of non-pharmacological therapy interventions for EIB. These include improving physical conditioning, warming up for at least 10 minutes before exercise, covering your face and mouth during cold, dry weather, as well as exercising in a preferably warm and humid environment. Also, another thing you can do is avoid pollutants like from cars or even running by the road, preventing things like that, cooling down gradually, lowering the intensity before stopping the exercise, or waiting even 2 hours after a meal to exercise can all help prevent the symptoms of EIB. There's also some pharmacological therapies that you can use, such as beta agonist, cromolyn, and inhaled corticosteroids for anti-inflammatory properties, but EIB is not an anti-inflammatory condition, or is not an inflammatory condition. It's rather those small, smooth muscles contracting in the bronchioles that cause that decrease in the airway, in the airflow. So those would not be as effective as perhaps a non-pharmacological treatment. So my first article is actually called Exercise-Induced Asthma and Cardiovascular Fitness in Asthmatic Children. And this was written by B.J. Theo, A.F. Nagelkirk, and A.G. Kettle. Now, the purpose of this study was basically to determine the relationship between cardiovascular fitness and the effects of exercise-induced asthma. They basically took 28 children aged anywhere from 6 to 13 with mild to moderate asthma and dyspnea and put them through cardiovascular exercise to determine basically their cardiovascular functions. Now, all these patients had their basal forced expiratory volume assessed, and they compared those expiratory volumes from before and after exercise. They also compared this to the peak VO2s of all these children. Now, they found no correlation between the VO2 max and the percentage in the decrease of the expiratory volume. So, in conclusion, they found that the normal cardiovascular fitness of these children did not prevent any exercise-induced asthma symptoms. So, the children and subjects with higher cardiovascular fitness didn't have any separate or different symptomatic responses to exercise than the individuals with lower cardiovascular fitness. So my second article is called Screening for Exercise-Induced Bronchoconstriction in College Athletes. Now, previous studies have tried to show that EIB is more common in athletes than in non-athletes. So this study tried to look at that as well. They tested 144 college athletes from Division I schools in order to test this. So essentially, they used an euconic voluntary hyperventilation test to test for the presence of EIB. Now, they also used exhaled nitric oxide quantification to be performed immediately before the hyperventilation test, before exercise, and after exercise. Now, they found that only 4 out of the 144 athletes actually had EIB, but 2 of them actually tended to actually said that they did not notice any symptoms or feel any symptoms of EIB. So, in conclusion, the data of the test argue that the screening for EIB is not recommended given the surprisingly low amount of EIB in these college athletes that they studied. So also the presence and the absence of symptoms was not predictive of EIB, and the nitric oxide test was not effective in predicting EIB. And this article was written by Jonathan Parsons, David Cosmer, and Gary Phillips. Thank you very much, and have a good day.